Hi, my name is Peter. I'm an emergency physician working in Stockholm and originally from Denmark. And today I want to talk with you about dizziness. And I did this lecture a couple years ago for the Danish Emergency Medicine Conference on dizziness. And since then, some things have happened. More studies have come out, and we've become more and more certain in this paradigm shift that we are that's happening and has been happening the last couple of years. So I thought I wanted to do an update video on just going through some of the things that I think are important in dizziness. And yeah, I thought it was time to do that. So let's move into let's move through this lecture where I'll go through this. I guess it's sort of still a new paradigm, but I'll put brackets around new because this should be the manifest paradigm now that are used in the emergency departments all around the Western world, I would say. Okay. So before getting into the lecture, as always, I'd like to show you the references and some go-to links because I don't believe what I'm saying. Please look at the literature and make up your own mind. I cannot recommend Peter John's YouTube channel enough. He's a great teacher in dizziness, and he's made video upon video about both the bigger topics in dizziness in the ED, but also the more nuanced topics. So big or small, new or old to dizziness in the ED, please go to his channel because that is really gold. And he does do a lot of good, like he makes his videos so that there are references, so that you can go check out yourself and read yourself what you need to know. It is important to say that Peter Jones is one voice in this space, and there are different voices, and he does not always agree on all the nuances, but in large, they all of these voices in this new space, this new paradigm of dizziness in the ED, they agree like 95% of the time, but there are a few nuances that they don't agree on, and some of the people that Peter Johnston don't always agree with is Jonathan Edlow in like really nuanced questions. But the important question of acute vestibular syndrome and how to define that is oftentimes something that he talks about on his channel, and how do we actually define that, and where they may have different opinions. So Jonathan Edlow, Dr. Newman Toker, Tanutzer, Qatar. There's a lot of, like, if you go through the names of, for instance, this article here, then you can see like all of the voices the last couple of maybe 15 years since the Qatar study came out in 2009, where you can see who's who in dizziness, right? And I guess that does kind of give us also, like, even though it's really a great group who are really invested, we should always be aware that this may also be an echo chamber, right? We need to be critical about what's going on, and we shouldn't just hype ourselves up to believing this is the only thing. We should keep doing studies and keep think critically about what we're doing, especially because these are diagnostic tests. These are not like perfect, and they're definitely not perfect when done by novices who don't know what they're doing. So we need to keep on educating people about these things. And despite all of what I just said, I think almost all of us, and in this space, we kind of agree on the method, like at least 95% of it. So Peter Jones' YouTube channel, check that out. That's the main reference I would give you. But if you want to go into the literature, then some of these articles are really like good ones to start off with, especially the new Grace one, Grace 3. Yeah. And if you wanted to know the nuances about BPPV, then check out this clinical practice guideline from 2017. It goes through all of the stuff there. All right. Word lists. Part of the reason why dizziness, this new, like even with the old paradigm, but also the new paradigm of dizziness, is kind of It can be a bit tricky because there's a lot of words, and some of the words have to be there are a bit of nuance to how you describe what you're finding, and if you are not doing it right, then you can make it sound like nothing is wrong. For instance, if you say that the hints test is negative, well, what do you mean by a negative? Because it can. I kind of know what you mean, but not really. The hints test cannot be negative or positive. It can either be pointing towards peripheral disease, or it can be pointing towards pointing towards central disease. So once you go into the hints test, you cannot be negative or positive. You can either be peripheral or central. And if it's peripheral, then you think it's vestibular neuritis. If you're central, then you think it's a central cause, most likely stroke, right? Or you cannot rule that out at least. But if you call it negative, then like the way I see a lot of people still using the hints test is by saying, oh, hints is negative, then it must be benign cause. I can send the patient home, and that is a wrong way of using the hints. It's the wrong indication. It's the wrong way of doing it, right? So that's why the words matter in this space, and I just wanted to make clear some of the words. So here are 3 slides of words and how I've picked up like kind of what I think is the essential words and what they mean. All right, so dizziness. So we talk about dizziness plus. So if I talk about dizziness plus, I mean dizziness plus something else. That could be serious symptoms such as syncope, severe headache, or neck pain. If you have a diving history, if you have severe bradycardia or tachyarrhythmia, that explains your dizziness and so on. If you have neurological symptoms or findings beyond those included in the monosymptomatic dizziness down here, I would not call, like, it's a kind of a misnomer. Like if you have neurological symptoms, then it would not be monosymptomatic. All right, then it would be dizziness plus. But I guess some would say like maybe you have a bit of tinkling. Some would call that neurological. And it really depends on the description of the tinkling. Like if you're hyperventilating because you're kind of dizzy, right? Then it's definitely something that could be described as like monosymptomatic. But if it's one-sided and it's more severe, then maybe not, right? Then you have to consider strokes. But most patients will not have this like difficulty of classification. You will just have dizziness without all of these symptoms. Another thing I've seen a couple of times is that the patient is kind of bradycardic when they come in, but not much, just a little bit maybe, and they look like kind of an ACS patient, like they may have almost syncopized, they are hyperventilating, they may be bradycardic, and we have to broaden our horizon there and think of other stuff than just dizziness then. But once you see that nystagmus on them, then you kind of can rule out a lot of the other more dangerous stuff because you don't get a nystagmus from a bradycardia, right? So then it's probably the other way around, that you are having bradycardia because of your nystagmus, because of it being a vagal episode, right? It's so unpleasant for you that you're becoming vagal, and I've seen that a couple of times. Okay, and then dizziness plus is also that your inability to stand. All right, so if you have dizziness plus, meaning like serious symptoms, obvious neurological symptoms such as sensory and motor deficits, or the dangerous Ds, as we'll come to, or you have an inability to like sit or stand unassisted, then that's dizziness plus. And then you can use the hints test, but you cannot use it to rule anything out. You have to treat those people as probable strokes or other dangerous causes until proven otherwise. So though for the dizziness plus, these algorithms are not for them, at least not for ruling out. Okay. Monosymptomatic dizziness, on the other hand, is dizziness without the above symptoms, but may include nausea, vomiting, or worsening of the gait function, but so that they can stand unassisted, but they may walk worse than their baseline. and they do not have any neurological deficits. Okay. The HINTS test is this conglomerate of 3 tests: the head impulse test, the nystagmus test, and the test of skew. And as we'll talk about, I like to take the nystagmus test first, actually. But just to show the acronym, here is the HI, the N, and the TS. That's why it's called the HINTS test. But the nystagmus should come first, as we'll talk about later. Because if the nystagmus test if there's no nystagmus, then you should not move it past those other tests. At least that's what Peter Johns would say, and that's where they kind of not always agree. Jonathan Etlow and Peter Johns. Okay, and that's my understanding of it anyway. So, and then you have the HINTS Plus test, which has come later. The HINTS test was validated, or at least it came about around 2009 with the Qatar study. And HINTS Plus test, I'm not sure when the hearing test came into the picture, but at least the last couple of maybe 6 or 8 years, the HINTS Plus test have been part of the algorithm. And that's just, HINTS Plus is just the HINTS test plus a hearing test. And then we talked about HINTS positive or negative. This term should not be used, not when you talk about it, and not when you're charting. You should instead use HINTS central or peripheral if you need to do that. Otherwise, I would specify the head impulse test with this finding, and the nystagmus test with this finding, and the test of skew with this finding. There is no shortcut, or when you use shortcuts, you really need to be specific with the HINTS test. You cannot say HINTS negative or positive. That is wrong. Then you have this very controversial thing called the acute vestibular syndrome, or maybe not very controversial, but that's where the argument is right now. And if you want to go into this a bit more, then please check out some of Peter Johns' videos. For instance, why are we still confused about the HINTS test and AVS? I can remember the link is here. So if you Google this, then you'll get to that video. But he defines, or he takes out some examples of definitions of AVS. And the oldest definition is the Balow-Hodson definition from '98. Acute onset of severe vertigo, nausea, and vomiting, and postural instability, and spontaneous nystagmus. Okay, so that's the most important thing about that definition, as opposed to the other ones. That in this one there's spontaneous nystagmus. It must be there. And in some of the newer definitions, they kind of leave out this, and I agree with Peter Johns. That is a problem that they leave that out, because as we'll again, I'm no neuro-ophthalmologist or anything like that. I have my background in partly in neurology, but and I've worked in neurology for a while. But I'm not an expert in any, especially not in neuro-ophthalmology. But when that is when you have acute vestibular syndrome, and if you have a Disney patient and they do not have nystagmus, then if you use the head impulse test on them, then it's quite logical that the test will be that would be like testing any of us. If I test anyone on the street with a head impulse test, then it will go towards central, right? Because it will be in a normal, and normal in HINTS tests is central. So that's the problem with having definitions without spontaneous nystagmus in them. On the other hand, if you do select the patients that do have nystagmus and they do have a normal HINTS test, normal HIT test, head impulse test, that will suggest that they have a central cause, right? So that's why I'm not quite. These new definitions are more maybe descriptive of the syndrome, and we don't really I don't care too much on how acute the onset was. I don't care too much whether the nausea, vomiting, or postural instability. These may well be there, but it depends on the patient's description of them. What is more tangible is the nystagmus. And in the Swedish Ljunggren definition here, Ljunggren definition, there's no there's mention of nystagmus, but it is not a strict criteria. And in this NAM definition, there's no mentioning of nystagmus, and that's apparently the definition that they use in the Grace, the Edlow paper, and the really good Edlow paper where they go through all of the stuff. But they kind of like use this really wide definition, and I think they, in my and I think Peter John's opinion, they miss the spot. They miss an important thing there, because you cannot use the head and pulse test on patients without spontaneous nystagmus, or you could, but it's not meaningful, because it would be a high likelihood of, it will just be false positive, right? Or false positive in the way that it will make you think that the patient has a central lesion, right? So that's the entire thing about the AVS, and we'll come back to that. But like if you have an AVS patient, it's all about picking out the right patient with AVS and nystagmus to do the HINTS test on. If you select those patients right, then you can actually use it as intended. Okay. So my definition here is of AVS, and this is no official definition, but I will just say constant dizziness, because these are a bit wordy. So I'll just say constant dizziness plus spontaneous and or direction changing nystagmus after lying still for a couple of minutes. That is like AVS for me, right? Then we could go into whether or not gait is part of it, or nausea is part of it, and so on. But that is the most, like, constant dizziness and nystagmus, that is spontaneous and not provoked, right? And that's why they have to lay still, because we should kind of eliminate the likelihood that it could be BPPV. So that's what we do when they're lying still. Constant dizziness would be dizziness that are like, it's not getting significantly better when they're lying still for 5 or 10 minutes, where their heads kept still. That means sometimes, as one of my good colleagues usually used to teach me when he taught me some of these dizziness maneuvers, keep a hand on their head while you're talking with them, so that you make sure that they're keeping their head still. So moving on, spontaneous nystagmus is, constant dizziness as opposed to episodic dizziness, where it comes and goes. And then you have spontaneous nystagmus. Spontaneous nystagmus is just nystagmus when your patient is looking straight ahead, right? And sometimes you may have to put a paper in to see to remove their fixation reflex, especially later on, like if they come on day 3 or 2, then it's really hard to sometimes pick out this, because the nystagmus is diminished as opposed to the first couple of days or hours. And I'll link to a video where you can use the paper see the paper test if you don't have Frenzel or any other device to remove the fixation reflex. Then you have gaze evoked or directional nystagmus, and that would be nystagmus when the eyes are looking up or down or to the left or to the right. And usually you should make the eyes look at 2/3 of the extreme, right? So if you can look, if you can make tell the patient to follow your finger, and then go all the way out to 2/3 of their extreme vision to the right, or and 2/3 of the on the left, right, or medially or laterally. And you'll have your finger at arm's length from their view, so it's not really close to them, but it's not so it's better to be a bit further away from them when you're doing this test. Okay. And this is what we mean, like these two nystagmuses. This is what is important in AVS, right? Then you have something called provoked nystagmus or positional nystagmus, and that is nystagmus that is being induced. It's not there when you are sitting down. It's there when you are, if you're doing this whole park test or the head roll test on, and then you can induce this. And usually it's concomitant with dizziness becoming worse, like subjectively becoming worse, and then you see the positional nystagmus becoming like being induced, and then it becomes worse, and then it becomes better after a while. And the important thing here is, as Peter Jones has emphasized, vertical nystagmus is normal and is the pathognomic sign of a Dix-Hallpike positive test if you're looking at the right direction during the Dix-Hallpike test, right? So vertical nystagmus is normal here. Doesn't mean central, but it's on the other hand, if you have when you do the Hintz test and you have a vertical spontaneous nystagmus, that's a problem. That's a central sign. Then you got the thing called triggered, as in a triggered episodic vestibular syndrome. This means, like, the way I usually explain this is if you have a patient who is not dizzy at all, like maybe 5 or maybe 0% or maybe 5 or 10% dizzy at rest, but then once they move their head to the right, then they or turn around in bed, then they become 100% dizzy or 90% dizzy, like goes from 0 to 100 right away. That's a triggered, and it goes down usually because it's BBB. And we should look at we should look upon that as opposed to worsened, because worsened is just, oh, I'm dizzy, maybe 95% dizzy or 80% dizzy, and when I shake my head or when I turn or when I move or when I walk around, then my dizziness becomes maybe from 80 to 90%. That doesn't mean that that's not triggered, that's just worsened. And worsened dizziness is something that is not at all sensitive, not at all specific for anything. It's just something that is there for all kinds of dizziness. Even if I'm not dizzy, I might become a bit lightheaded or dizzy if I'm moving my head around. And that's the same thing if you're dizzy. But triggered is a different thing. It's from 0 to 100 within seconds because of some kind of movement. And it's really important, those nuances. So those are just the first page of the nuances. Next one. The next one are important words here. So vestibular neuritis. Usually you'll have a vestibular neuritis, or like pathognomic findings of vestibular neuritis would be, a bit of danger. It's nystagmus that is unidirectional. Usually it follows what you call Alexander's law, meaning that if you look to the nystagmus is present and beating towards the sick ear, right? Unidirectionally. So when you looked, like, let's say that your patient's ear is sick to, like, the left ear of the patient is sick, meaning that the nystagmus will beat to the left. And once the patient is looking, if you're telling them to follow your finger towards your left, towards the left ear, towards the patient's left ear, then you will see a more severe nystagmus as the eye comes closer to the left ear. Sorry, it's difficult to explain these things. All right, but if you then make the patient look more towards his right ear, then the nystagmus will become less and less. And then if you go towards the left ear again, it'll become more and more. So that's what you call Alexander's law, that it's beating towards the sick ear, and it's become more and more pronounced the more you are looking towards that ear. Then in vestibular neuritis, the test of skew is negative. Here you can say it's negative. And the head impulse test will have a catch-up saccade, and this catch-up saccade is when you turn the head from. So if you go with the example of the left ear being sick, then if you quickly turn the head to the right, 15 or 20 degrees, then you will see a catch-up saccade, hopefully. And if you see that catch-up saccade and you don't have any hearing loss, then it's a vestibular neuritis. And you don't have any neurological findings and so on, right? It's a monosymptomatic dizziness. And if you want to see it catch-up saccade, then please check out this video from Peter Johns. Okay. The thing is also that with vestibular neuritis, these catch-up saccades become harder and harder to see later on in the disease process. So if they present on day 2 or 3, or if you've treated them with antihistamines or benzodiazepines, then it becomes harder to see as well. And sometimes it's a minor vestibular neuritis, then it's also harder to see. Okay, so sometimes you want to pick out your camera, take out your camera and film the thing. in slow motion. All right, then you have labyrinthiasis. Labyrinthiasis is the daughter syndrome of vestibular neuritis. It presents in the entirely same way, though with hearing loss as well, usually, or at least hearing affection on the sick side. And usually there are other telltale signs. For instance, they will usually be I've seen 2 in my career, and they have both have had CRPs that are high, and they have been subfebrile. But they I'm not sure, like with the HINS plus test, the problem is that if you have hearing loss, if you have all of these things, but you have hearing loss, then you should consider an ICA stroke. And I've not been given a good answer on whether you should do, like, whether the CRP and the like infectious nature of that presentation is enough to say that it's not an ICA stroke. In the 2 cases I've had, it has been the case. At least the ENT doctors thought so. It presented classically enough, but I guess there are some non-classical presentations where you have to consider ICA strokes instead. Okay, then you have to think about truncal ataxia versus worse gait. So, if any patient with dizziness cannot, who used to be able to stand and walk without problems, and now cannot stand or walk unaided, and cannot sit unaided. Like if you're sitting, then they fall down, and it's not just because of like tiredness or something. Like you can assess them in a good way, and they can really not sit. Then there are you have to consider that they are truncal ataxic. And if they're truncal ataxic, that means that they may have what you call the acute imbalance syndrome if they don't have any other signs, like nystagmus or anything like that. And that's a stroke until proven otherwise. We have to, that is opposed to just having worse gait, because the patient with vestibular neuritis will have a worsening of their gait. They will be worse than usual, but they will be able to stand and walk. Okay, so they walk a bit drunkenly, but they will be able to walk. And here comes the problem with when we're assessing dizziness in patients with alcohol in their blood, or because some patients may have Wernicke's, and you have to consider that as well. But and some people may have stroke and alcohol in their blood, and that's a problem as well. It's hard to, like, there's too much noise to be sure there. And also you have a lot of elderly patients who cannot walk at baseline. So if you, and those patients can sometimes be hard to assess, because even if everything else looks like it's peripheral, then they cannot walk unaided. And if at baseline they cannot walk unaided, well, I guess that's clinical. Like you have to like assess the clinical risk of them having a stroke. And maybe you have to admit them to do an MRI just to be sure. But most times it will be what you think, like usually maybe BPPV or vestibular neuritis, something like that. Yeah. Okay. Then you have this, as I mentioned, acute imbalance syndrome, coined by Machner in Björn Machner. I guess he's German. It's a German paper. And the thing about that, he defines that as, or they define this as, acute onset of an unsteadiness in stance and gait, still persistent at the ED presentation, no spontaneous nystagmus. So these are patients that are the unsteadiness is that they have this truncal ataxia. So we kind of wanted to have like some kind of grading here, and my grading, like the way I graded is, can they walk, sit, and stand unassisted, meaning don't hold the walls. Meaning that they, I'm not afraid. Like they can walk without holding onto anything or anyone, and they can sit without holding on to anything or anyone. All right. If they can do that, even though it's way worse than you would expect for the age, then it's all right. And there is an official way to determine this. It's from this paper. This is from the Etlow paper, and originally it's from this paper. And there's like 3 grades. There's grade 0 to 3. And I guess you would say the grade 0 to 1, they are usually not having a stroke. or they're like, if everything else looks normal, then you can send those home. Edlow has said that in one of his papers. And I don't know, I actually haven't written, or I haven't read the original paper here, but 7% here is probably, they probably had some kind of other signs of stroke that would make that the Edlow algorithm not like apply. But if you have dizziness, or if you have severe imbalance, or you're like postural unstable, like you have to, then it's a stroke until proven otherwise. All right, so that's kind of the same thing I just said. But please check out the paper and comment if you have any suggestions about this. But this is also the opinion, I think, from Jonathan Edlow, that if they can kind of walk unassisted, he has videos where he with you examples of this, then it's all right. All right. Last page of terminology, and then we'll go into the lecture. So BPPV, or ear stones, or benign paroxysmal positional vertigo, has two kinds of, like two versions. There are canalithiasis, which is like otoconia or ear stones in one of the canals, that is, or that's what we think, and that's the mechanistic like way of thinking about this. Of course, it's sometimes multifactorial, but mainly this is the thing, because we have a treatment that can actually get the stones, or what we think are stones, in place, with the, for instance, Epley's maneuvers. So this is the most common one, canalithiasis, and you have what you call cupulothiasis, where it's not the ear stone. It's the ear stone being thought to be stuck on the cupula. Remember, maybe you may remember that the canals are like this like system where in one end of the system there's a cupula, and if that's turned, then you kind of that sends signals to your brain. And sometimes you have cupulothiasis, which is thought to be ear stones, which are thought to be stuck on the cupula, one of the arches or one of the canals. And it's characterized by this more prolonged symptoms, and these can sometimes be a bit harder to diagnose because they may present stroke-ish or ABS, like may present more like acute vestibular syndrome sometimes. So these can kind of be tricky sometimes. All right, so BPPV syndromes, you have your posterior canal, PC, BPPV. These are treated with the Epley's maneuver, and these are the most normal ear stones, right? I didn't update this, but in recent years it's become more and more common to actually say that probably these are not 75% in the ED. It may be 75% in the ENT outpatient office several days after onset. But in the ED, the other one, horizontal canal, BPPV or HC-BPPV, it's probably much more common than we think, but they just heal, or they heal faster and more spontaneously, and so once they get to the study population in the ENT outpatient's office, then they have healed, and that's why they're not seeing those. But in the ED, we probably see much more, much more, and these are treated with something called the Guffoni maneuver. Okay, and these are probably, as we said, underdiagnosed. They're tested with something called the supine head roll test, where the posterior canal is the Dix-Hallpike test. And we'll get into when they're positive, but in short, with ear stones on the lateral canal, nystagmus will be seen with testing on both sides. And that's not the thing. That's not the case with the posterior canal, BPPV. And in the horizontal canal, if it's a canalithiasis, then it's usually beating towards the ear. It's beating towards the ear that is sick. Where the nystagmus is strongest, that's where the money is. We'll get into those things later. And yeah, they can present with different kinds of nystagmuses, geotropic and apogeotropic. Nystagmus, geotropic meaning beating towards the ground, and apogeotropic meaning beating towards the sky, right? And then you have the last ones, which is anterior canal BPPV. These are like less than 1% of all BPPVs and can present with downward nystagmus on Dix-Hallpike test, but due to its rarity, downward beating nystagmus should be treated as a stroke until proven otherwise, according to Etlow. That is downward, not upward. Upward is normal. Downward is not normal in Dix-Hallpike tests. Yeah, or at least it's something. It's so uncommon that you should consider it be stroke. And that's why we go into details with these things, because it is, if you want to rule out a stroke by ruling in BPPV, you really need to make sure that it's actually BPPV, and that's by doing. And you need to know the nystagmus is, or at least kind of know the theory to be able to do that. And which ear is the sickest, at least in horizontal canal and also in posterior canal. The rule is the direction in which the nystagmus is strongest. It's like, so it's beating towards the sick ear. And if you have a Dix-Hallpike positive to the right, like if you lean the patient down, if the head is to the right and you're putting out the patient doing the Dix-Hallpike test, and you get a geotropic nystagmus beating towards the downward ear, then that's the ear that is sick. Okay. And if you do a head roll test on the horizontal canal BPPV, and you get a bit of nystagmus maybe to the left, but you get most of the nystagmus when you're doing it to the right, and then it's the right ear that is sick. And oppositely, if you get an apogeotropic nystagmus on a lateral canal or horizontal canal BPPV, if it's the apogeotropic, meaning beating towards the sky, then if you move the head to the right and it's really strong apogeotropic, that means it's the left ear, because it's beating towards the ear that is strongest. That's the opposite ear. That's where now we're getting into the weeds, and we haven't even gotten into the lecture yet. So this is just a terminology. Okay, then you have something called pseudo-spontaneous nystagmus, PSN. Pseudo-spontaneous nystagmus is nystagmus seen in BPPV at rest. And the incidence varies, and this is a problem sometimes with when you see patients really early on. Sometimes they will have nystagmus even when you're lying still 5 or 10 minutes. They have kind of an AVS-like presentation, and how common this is kind of semi-unknown. Some studies will say that it's not that uncommon, and maybe a bit. Like the two studies on this are that I've quoted here says that it's quite common. But then again, if the history sounds like BPPV, and when you do the Dix-Hallpike test on these patients, then and you get the typical nystagmus, then it's BPPV. The problems are if you have someone who you think has spontaneous nystagmus, and then you have to treat them as an AVS, right? And you have to do the AVS test on them. So, and this is where sometimes I think I myself and Peter Jones sometimes are not total agreement. I think it's not too obvious always when the patient presents, especially early on, whether they are a BPPV that is AVS-like or an AVS totally. And if you have a BPPV that is AVS-like, sometimes it's okay to do the Dix-Hallpike tests, knowing that you should not do, like, as we'll get into in the lecture, either you have AVS or you don't, right? But to be considered an AVS, you need to know that they have spontaneous nystagmus, and they're constantly dizzy, and this can sometimes be a hard evaluation. So I would say, once you've done your initial evaluation, then you kind of do what seems like the most likely. If everything points towards BPPV, but they still have a spontaneous nystagmus, then I'll do the Dix-Hallpike test, and if it's not clearly positive, then I'll do then I'm kind of okay. Then it probably was a true AVS. But if it's clearly positive, then it's BPPV, and then I will be done. Um, so, but this is where it gets like clinically controversial, and yeah, you can always comment on what you think about this. And then we talk about subjective test positivity, and like we do a Dix-Hallpike test or a head roll test, you can see the nystagmus, that's a objective positive test, or you can hear that the patient, oh, now it's coming, and they become dizzy, but they may not, and usually the dizziness comes with the nystagmus and vice versa, but not always. And sometimes they are only subjective positive, and then you have to consider, well, was that a good positive test, or should I consider other differential diagnoses? Depends on how the other risk factors are in this patient. Okay, moving into the lecture. That's 40 minutes of terminology. Sorry, but it's really important that we get this terminology out of the way, because that's usually where the problems are when we're talking about this thing, this new paradigm of dizziness. Okay, so the old way. Peter Jones has done these great videos on this, like these old graphs or these old tables has been in all and every book in the universe in medicine when it comes to vertigo. It's like either central or peripheral, and the central is like, it's usually like peripheral is usually sudden onset, the other is gradual onset. This way of thinking about the approach to dizziness is illogical, and it doesn't make sense anymore. That's why we've moved to the new paradigm. It's still okay to talk about central versus peripheral vertigo, but not in the way where we say like, oh, these are the symptoms of central, these are the symptoms of peripheral, because a lot of the, like, they mix, like the central vertigo. I mean, if we just take AVS, vestibular neuritis, and stroke, the reason why we even need the HINTS test is because vestibular neuritis and stroke, when presenting monosymptomatically, are really hard to tease apart, and it's actually impossible to tease apart just using your history and your neurological examination. You need the HINTS test, and that's the thing. That's why we cannot use this paradigm anymore, because it's old and was not validated in a good way. So we need to move beyond this. And if you want to get into the weeds about that, please check out the Peter Jones video down here below. Okay, Tanutzer made this even more clear in this study here, where they show that, well, if you only use the old paradigm where you do neurological examination and gait tests, then you have a quite bad negative likelihood ratio, meaning that these are not good enough tests to rule a dizziness out, right? Or a stroke dizziness out, right? Even you may even throw in the CT scan, which is negative in falsely negative in something like 10 or 20% of the time, right? So, and even the MRI, if you throw that in, would be and it's only positive after, is only good to use after 48 hours. That's when it gets this characteristic likelihood ratio of negative likelihood ratio of 0.21. That's after 48 hours. So within the first 48 hours, we're kind of screwed. We cannot admit everyone, right? So that's why the HINTS test was developed, and it has a much better negative likelihood ratio as within the first, like, from symptom onset. And then just a little bit about terminology as well using this paper. So once you have a HINTS test that points towards the central cause, then you cannot say that it is stroke or a central cause yet, but you can say that you're not sure. Yeah, you cannot rule it out, and that means that you have to treat it as such until proven otherwise. And sometimes these patients will need the MRI after 48 hours, or repeat tests in the neurological department, or other tests to make sure, right? Because the positive test is good but not great. It's like between 5 and 10, and that's okay. On the other hand, if you do have someone with truncal instability, like grade 3, then that's definitely a stroke until proven otherwise, unless they have alcohol and so on, other causes in their blood. And if you do find something on the MRI, that's also, but that's after 40 hours. Okay, so take home from this is MRIs miss 20% of strokes in the first 40 hours from onset of symptoms. And I think I cannot remember actually, but I don't think the MRI becomes much better like than that. I do think the sensitivity is suboptimal in the MRI as well, even after 40 hours, but I cannot remember. Then the CT scan should not be used for traumatic, and then CT scan should not be used in general, in like not to diagnose anything in vertigo, but you may have to use it once you have a HINS test that is as central, because if it's essential, then it's almost always a stroke until proven otherwise, right? And then you have to do the CT scan as a stroke protocol to just make sure that there's no bleeding before you start with ASA, acetylic salicylic acid, right? So that's when the CT comes in, or when you have a traumatic vertigo. Then you may need a CT scan as well, especially in the alcoholic patients or patients with a high risk of bleeding. But other than that, in a non-traumatic monosymptomatic vertigo, you do not need the CT scan. Okay. And the HINS plus test is the best test for the AVS in the ED. And the AVS is defined with nystagmus. Okay. So should we just use HINS on everybody then? Or, well, when the HINS test came out, and a lot of my colleagues are still, and I'm saying a lot of my colleagues, I stand on the shoulders of giants. I know these things because others have taught me, or so I'm not pointing fingers or anything, but I'm just seeing a lot of charts where there are where the HINS test is being used as a hammer to all the dissipations, which would be nails, right? Dissipation, I just used the HINS test. It was negative. Ruled out. I can send them home. That is not how we use the HINS test, and that's one of the main themes here. If you take nothing else away from this lecture, that is what you should take away from it. That is your take home. Don't use the HINS test unless the patient is dizzy with nystagmus, and it has to be spontaneous nystagmus or direction changing nystagmus. Okay. And this was like, we thought that, oh, this is amazing, the HINS test, now all our worries about this really complex group of dizzy patients can be solved, but no. And it's been, to no surprise, this study from 2021 and other studies from like one from Oli as well, which I have in one of the other Dizziness lectures, says that like, we are using this wrong, or like 97% of the time. So another take home from this lecture is that you should use the HINS test, but you have to be educated on how to use it. And hopefully there's a champion in your department who knows about dizziness, who can teach you, or maybe you can even teach yourself through these videos. We don't know how dizziness should optimally be taught. Bani, one of the other authors in Italy, of one of the algorithms called Standing, they used a program and with emergency physicians, I think it was 10 hours, something like that, where they went through it. And that's one way of doing it. I think we could think about this like point of care ultrasound. A lot of the things that we do in point of care ultrasound is something that like is quite low hanging fruit. It's quite easy to learn, but you have to learn it, and you have to learn the basics. And I guess a lot of things, like probably this could be said with a lot of things in emergency medicine, but now we've focused on this, and I think I like having a driver's license in dizziness with 10 hours course or something like that. That would be good. That would be great, right? Certified dizziness expert or ED expert in dizziness or whatever. I think that is the way to go. We have to be able to educate people about this before they just use it, because just releasing something, and it's not just for the HINS test, it's for everything, right? It's for everything. that if we just release it, oh, this test is really good, but you don't know the indications. I bet if you used the Wells score, or you used any other score on and looked at how if you just release it to the masses, and you don't educate people about indications and so on, then you'll get what you call indication creep. You'll just use it on everyone. So this is not specific to dizziness, I think. It's just normal human behavior, especially with a complex patient group where we are lacking, or have been lacking in getting good tests to differentiate them. So what do we do instead? Well, we should think of the HINTS test as, or we should think of the dizzy patients as this mountain of dizzy patients. I think it's like 3% of all patients who presents in the ED. And so HINTS test is just part of our toolbox, right? We need to do a neuro exam. We need to have other tools as well. We need to do history and so on. So this is just one tool that we can use, but should only use for specific patients, not all of them. And if you look at the data from EDLO, then you will see that 10% of all dizzy patients have neurological causes. 1/3 of those have stroke. 33% of them are ENT problems. So maybe 45% of them, a little below 50, are like neuro-otological, which will have nystagmus one way or the other. But most of them are actually medical. If you use the HINTS test on medical patients, as I said, that's like using it on me sitting here healthy and well. It'll be pointing towards central cause. And that means an admission for me. So don't, like as with everything in all of medicine, know the indications for using the test. Okay. And you might see up here, AVS is the keyword here. It has to be the AVS. It's not HINTS test for everyone. It's HINTS test for AVS patients. Right, and we will define this with AVS with nystagmus. So here, constant dizziness at rest and spontaneous or case-evoked nystagmus after a few minutes of rest, to rule out the pseudo-normal BPV kind of nystagmus that sometimes occur. Okay, so the new way. There's lots of algorithms, and more algorithms are coming out. This is the big three, I call it, from Peter Johns. I think he calls it he calls it that as well, and maybe not officially, but has a video called the Big Three of Vertigo. And so I would call this the Big Three algorithm, because there are 3 legs. There's the kind of BPV leg. There's the kind of AVS leg, and then there's the this patient has dizziness plus leg, needs to go on. And I think this is probably the best of all of the algorithms. But I'll just show you some of the other ones. The reason why I think this is the best one, I think it's more simple and it's kind of easy to use. And there's even a video with it, which I greatly appreciate. And Peter Johns has also cleared up this kind of central versus peripheral with this graph, where you can see, well, BPPV, vestibular neuritis, cerebral stroke. This is the way the table should look, and here you can see why the central versus peripheral is kind of not working out. Okay, then we have another algorithm. I mentioned VANI, which is an Italian study, the VANI study, which is, to my knowledge so far, one of the only studies who actually tested emergency physicians, giving them the tools to know dizziness, and then gone through all of the making emergency physicians do the workup. And when you have standings, and the reason why it's called standings, I think I'll just go to the next picture because it's a better version of it, an updated version. The reason why it's called standings is because it has these is an acronym that's kind of hard to figure out, I think, but it's kind of the same as Peter John's, and where you also have like if you fall down, if you have the acute imbalance syndrome at the end of it at all, you have to admit those patients as well. So spontaneous nystagmus, yes or no? Well, no. Then is there positional nystagmus? Meaning that you do the positional tests. Yes, it's with the Kolpak test or the supine head roll test. Then they'll do that, and then you'll ask, can they stand or walk independently? If not, then they'll be treated as central cause. And this is where, well, there's lots of these patients, especially the older ones, that at baseline do not walk or stand normally. So a lot of them will be treated unnecessarily here, but it's at least better than doing like than treating everyone as it. So this is where we probably could use more studies on how to, like, the patients who are still at baseline not walking, how can we differentiate those? But this is also a good algorithm, and an algorithm that is being used in Sweden, I know, in some centers. Then you have the attest algorithm, which is, again, these all of them are saying the same thing. It's the same people, like this is ETLO. It's the same, like, kind of same focused, like dizziness interested people with an ED focus who's been doing these studies. And I think that's great, but with some caveats. And that's why I'm showing you different ways of cutting these algorithms out. So this is the attest, right, from ETLO. Yeah, and I'd like to move on to this one. Actually, it's also ETLO, and if you have someone, he has like this is kind of I kind of like this one because it's kind of intuitive. If you have someone with acute onset dizziness, then is there a central pattern? There's 5 questions, right? Is there a central pattern nystagmus? No. Is there skew deviation? No. Is there head impulse test negative? I would not call it negative. I would call it peripheral, but and then again, it only applies if the patient has nystagmus. This is Etlo saying this, so he's kind of in agreement here with Peter Johns. Are there any CNS signs focused on focused neurological exam? Well, Peter Johns would probably put this up here, but anyway, because that's dizziness plus, and you do not do hints on the ones who are not dizziness plus. You can, but they're stroke ruled in anyway. There's a nuance, but okay. And are they unable to sit or stand or walk? No. If you have this is for the AVS patient with nystagmus, right? He says that himself. So if the patient has nystagmus and they have all of these tests are negative, then you just treat them as vestibular neuritis. You would also do the hearing test now. So a 6th question here, but that's good to say, like, okay, these 6 questions are negative, then or pointing towards peripheral, then they can walk home. Yeah. Then you have a newer version of this Etlo algorithm in general for all dissipations, and I think this is a bit messier. And I know Peter Jones doesn't like the AVS, sEVS, tEVS syndrome kind of way, because he likes to call it BPV because that's the most common triggered EVS. But I guess, yeah, this is I kind of like to hold on to this way of saying it, because there are yes, the AVS is most likely central stroke, and yes, sEVS can be different things, and yes, tEVS can be different things. But if you kind of, in Peter Johns's, that's like you kind of miss the sEVS sometimes in his algorithms, or it's kind of hard to find, and and the medical courses there can sometimes like it's 50% of all patients with dizziness, right? So some of them are dangerous, and you need to kind of pick those out as well. Okay, anyway, so that's why I'm also showing you these different algorithms. They can do they do different things. I don't think one is much better than the other, but if I had to choose, it's Peter Johns's, but just with a few additions maybe. Okay, so going through this, initial exam shows obvious neurological findings. Well, no. If so, initiate stroke protocol, right? Clinical evaluation suggests a non-neurological general medical cause. well, if you have an ECG finding or if you have some kind of everything, well, no. Then it's monosymptomatic, and then you can do this. What is lacking from this is that they need to be able to stand and walk, I see. Right? So I think it's I think again, I think no algorithm of these are perfect, but they're kind of lacking in different ways. And here's just just moving through the other algorithms. The one previously was Newman-Toker's algorithm, and here's Tehrani's algorithm as well. Again, Etlo has been on this one as well, and Qatar and it's the same names, right? So same people doing kind of the same stuff. Okay, so this is a new approach when I explain it in a nutshell, and I'm not saying my algorithm is better. This is just my way, how I understand it. Okay, so you have your undifferentiated mounted of patients who are dizzy in the ED, and you want to sort out all the patients so that you get this monosymptomatic dizzy patient, which you can use the HINTS test or standing tests on, and so on and so forth. Okay. So the first part is, what is a patient's problem, right? And this is something that Etlo is opposed to, right? And we probably should move away from putting too much emphasis on asking the patient, oh, what kind of dizziness what do you mean by dizziness, and so on. But there is some kind of assessment to begin with, like to know whether, like, is this something or is this nothing? Is a data point that is not unimportant to kind of gauge what is this? Is it in balance? Is it something? And I guess with the new paradigm, we should quickly test if they have nystagmus. We should quickly ask the questions that are important in this paradigm. But I don't think it's unimportant to kind of get the patient's story, ask them a broad question, and then let them tell what has happened. Because sometimes when they tell their story, it doesn't point towards dizziness at all. It points more towards tachyarrhythmia or bradyarrhythmia, maybe some kind of other episodic phenomena. So I think it's important to what is the problem here, and most commonly it's not that hard, and you can check out if they have nystagmus and so on quite quickly. And this is where it comes from. The symptom quality paradigm comes from methodological flawed studies from 1972 that was embraced by medical establishment. This approach is based in first taking a dizzy patient, what do you mean by dizzy, right? And then using the response to generate differential diagnosis. And for this approach to work, two facts must be true. Patients should be able to consistently choose one and only one dizziness type, and each symptom type should be tightly linked with a given differential diagnosis, and both are demonstrably false according to Etlo. So in a study of 2007, ED patients with dizziness were asked a series of questions aimed at determining reliability and consistency of eliciting symptom quality and timing and triggers at dizziness. And when the main questions were re-asked, an average of 6 minutes later, half the patients changed their primary dizziness. So it's unreliable to go too much to rely too much on this, right? And I agree on that. This is from this article. Okay, that's why in 2009 they kind of went, oh, we need something else here, and that's why Qatar and all made the HINTS study. So then we have to rule out the HINTS positive ones, right? So we need to, there are neurological deficits, what you call the dangerous Ds, the dysarthria, the diplopia, dysphagia, dysmetria, dysphonia, and also Horner syndrome. Moderately to severe ataxia, like truncal ataxia, as we talked about, like they cannot stand or walk, or they have finger-nose test that is abnormal, and they have some kind of obvious lateralization sensory-motor syndromes, right? These are obvious neurological findings. What I would say that sometimes you will see someone who has obvious neurological findings that are intoxicated or alcoholic patient, where you could be Wernicke's, and where you have to treat with thiamine instead. Maybe you have to go the stroke pathway as well, but you at least consider treating with thiamine as well. And think of other things. Then there was the thing, cannot stand or walk without assistance, and we talked about the grade system Is it the baseline? All patients in this Qatar study from 2009, all patients were unsteady, i.e. broad base gait or difficult with tandem walking, but severe truncal ataxia, inability to sit without the use of arms or assistance, was seen only among those with central lesions. So we're talking about the difference between the grade 0 to 1 and 2 to 3, right? That's where between 1 and 2, that's where the differential is, right? Below 2, that is not stroke, and 2 or more, that's stroke until proven otherwise, right? That's what Qatar is saying as well. Okay, then you have other red flags. If they have had syncope, you might think of subarachnoid hemorrhage or arrhythmias and so on. If you have chest pain, you might think of ACS, dyspnea, PE, head or neck pain, then you might think of vertebral dissection maybe, and you have to do a stroke protocol anyway. Alcohol is it's hard to diagnose these patients when they're doing alcohol, so it messes things up a bit, right? So, and diving. If they've been diving, then there's a specific trigger, or if there's been a specific trauma as well, then there's been a specific trigger. That's what you call the triggered acute vestibular syndrome, and that's something that you need to work up as a trauma, if it's a trauma, and work up as a diving accident. If it's a diving accident, I will ask an ENT doctor right away, and about barotrauma and stuff like that. Okay, and perilymphatic stuff and stuff like that. These things. Okay, if they're not any of these things, then they have monosymptomatic dizziness, and they are allowed to have worsening with balance and so on. I have a definition here right away. If they're here, then they're in stroke land. And it's important to think about, well, in these monosymptomatic dizzy patients, we haven't sorted out whether it's medical yet. So it still can be anemia, infection, hyponatremia, sarcopenia, polyneuropathy, anxiety, polynephrology, and so on. These are really common medical conditions, as we said. 50% of the ones undifferentiated are those, right? So here we're kind of ruling out the obvious ones. But we still have monosymptomatic dizzy patients, which may, without nystagmus, be these. Okay, monosymptomatic or isolated dizziness, the definition of that is vestibular symptoms may be characterized as isolated when the only associated symptoms or signs are non-localizing ones that routinely accompany vestibular pathology, meaning especially malaise, nausea, vomiting, nystagmus, and postural instability. The presence of new focal neurological symptoms, lateralizing weakness, numbness, dysarthria, diplopia, Horner syndrome, or limb ataxia, accompanying the vestibular symptoms would make the syndrome non-isolated, as would other general medical symptoms such as chest pain or dyspnea. That's what I just showed you. The presence of new hearing symptoms, i.e. or e.g. tinnitus or hearing loss, is an otherwise isolated vestibular syndrome, is called an isolated audiovestibular syndrome. Yeah, that's just a nuance, right? But you still have to think about, could this be an ICA stroke, or is this labyrinthiasis? Okay, so the big three kind of way of saying this is, I like the big three, but I like to call them AVS instead of, so you have acute vestibular syndrome. When you have these patients, now you have the monosymptomatic dizzy patients, once we rule out the dizzy plus patients. So you have your constant patient who are constant dizzy with spontaneous nystagmus. Those are these, and you'll do the HINTS test on those. And if it's HINTS plus test, and if it's all peripheral, and then you can check out if they can sit or stand, or if you have not done already, and if they can do that, well, then it's peripheral vestibular neuritis. Or it's a vestibular neuritis. If they cannot do if any of these tests are positive, or sorry, not positive again, but pointing towards central, then they are then they're stroke until proven otherwise, and you have to do a CT scan, and you have to do loading, or you have to consider embolectomy and all of those stroke protocol things, right? If you have your tEVS, you're triggered episodic vestibular syndrome, then you'll do the Dix-Hallpike test or head roll test, and if it's either is positive, right, and then you'll think, oh, it's BPPV, and you'll treat it if they have these specific nystagmuses. But if they don't have nystagmus, then you have to think, well, is this unspecific? Is it orthostatic? That's the second most common thing in the tEVS, and there are sometimes behind orthostatism severe disease can hide. So bleeding, for instance, can present like that. But most times orthostatism is something multifactorial, usually polypharmacy or something like that, even Parkinson's as well. And then sEVS, the spontaneous episodic vestibular syndrome, depends on how long it has lasted, like how long is each episode. Yeah. And these three syndromes, so it's a really short, if it's a really short episode, then it's usually like seconds, then it's nothing. Seconds to minutes, then it may be bradycardia or tachycardia, right? Especially if there's syncope or pre-syncope with it. If it's hours, then it's usually, then it can be many hours, but more likely it can be vestibular migraine as well. And if someone with an sEVS presents in their dizzy spell, then they will be treated as an AVS. Okay, then you'll follow the AVS algorithm. And if they don't have nystagmus, well, then you'll have to consider, like usually you can from the history pick out vestibular migraine. It's very common and often missed, but otherwise you have to think of the medical stuff, right? Here is from Etlow paper, the most like the grade 3 Etlow paper, where you can like kind of graphically see the definition of each of these syndromes. If you want to read this, you can do that. Yeah, and also graphically you can see how they're laid out. So, also from the Etlow paper, of all dizzy patients that they see, most of them are AVS, and their definition is without nystagmus, I think. And then you have your, and I guess in that way, like they should probably differentiate with nystagmus, without nystagmus. But anyway, then you have your spontaneous EVS, and then you have triggered EVS. So, and then I guess you have, yeah, and that makes 100% of all dizzy patients, right? The AVS is most benign and most common is vestibular neuritis if it's with nystagmus, right? If it's with nystagmus, if you have AVS or acute imbalance syndrome, then the one you want to rule out, that is the posterior stroke. But I want to make sure that you also know that especially Wernicke's syndrome is here as well. Labyrinthiasis is here as well. And there are other central causes. The reason why I like to point out Wernicke's is because you have to treat with thiamine in the ED to reverse this. And also medical drug toxicity, you can sometimes have something like that, maybe something reversible as well. The other ones, I mean, labyrinthiasis, as I said, that presents almost with like vestibular neuritis, just with a hearing loss, and that is kind of how do you want to evaluate that? Is an ICA or is it really inflammatory, meaning that, well, it's labyrinthiasis, then you treat it as that. The episodic vestibular syndrome most likely is vestibular migraine. That's the most common one, but it can also be panic attacks. That's really common as well. Pulmonary embolism is not common. And usually, I don't know why they put it here, because it's not necessarily something that comes and goes. It's usually something that is there and then it's constant. But anyway, and then Meniere's. That's something that comes and goes, but usually it will be accompanied by tinnitus or hearing loss. With each episode, it becomes worse and worse, but in the beginning, it doesn't necessarily have to be. Cardiac dysarrhythmias are here as well, definitely. And what you want to also rule out is posterior strokes. Posterior TIAs. And these are really, really, as we'll talk about in the end of this lecture, these are really hard to tease out and almost impossible. We don't know how. And it's a risk assessment each time, because a TIA is defined, at least the time criteria wise, is defined by not seeing anything on the MRI or any other tests, right? It's a risk assessment diagnosis. And if the symptoms are really specific, like motor symptoms that are like motor deficit, then it's easier. But if it's more unspecific, like dizziness, which everyone has from time to time, especially if it's really vaguely described, then it's really hard to pick that out. And I think Peter Jones agrees that, and also Jonathan Etlow agrees that there's no way to actually do this. There's no algorithm for this. It's a case by case base, and most of the times we should not think about it. And you have the tEVS, and most of those are BPV or orthostatic hypertension, as we talked about. Usually it's caused by non-life-threatening causes, but you can have orthostatism by life-threatening causes such as bleeding. You have this elusive CPPV thing, which I will not get into, but there's a cousin diagnosis CPPV, which is really rare, and I'm not quite sure how to actually diagnose it. But if you have a PPV that doesn't really act like it should, like with a downbeating nystagmus, where you think it's anterior canal, then that's probably where you should think about this. But you can look that up for yourself or comment if you want to. Yeah. Then we go on to this. What questions do we ask when you have your monosymptomatic patient to actually categorize these patients? And there are two questions that are important. The problem is it's not always easy to categorize these patients. In some patients, especially in those who present soon after symptom onset, and that's my experience as well, it may not be possible to confidently place the patient into one of these three categories. The episodic nature may not yet be apparent, and some patients will be with benign like BPV describe a vague but persistent dizziness. That is also my experience, that sometimes the BPV patients do not say, like, when I'm lying totally still, then it's 0. They have some kind of inertia in their dizziness to begin with, so that they have this trigger. Oh, it becomes worse, and it becomes better. But usually they're kind of panicky. Sometimes they're panicky and vagal to begin with if it's really severe. And if you get them really close to when they, like in triage, when they just presented, then it can sometimes be hard to tease out whether it's an AVS or it's a BPV. So I'll give you my method to kind of tease that out. But sometimes in the beginning it can be hard. And I guess that's where I kind of, as I said, that I might be a bit in disagreement there with Peter Jones, because as I understand it, he would think that you can always tease out which category the patient is in, and I'm maybe because he's such a great dizziness ED doctor and an expert in this field. But I think for most of us, there will be this gray area of patients, especially early on, and we have to kind of consider that as well. Similarly, some early presenting patients with mild vestibular neuritis may have minimal symptoms and at rest, but definite symptoms provoked by head motion, suggesting an episodic presentation. This is what a head motion. This is what we would call worsening, right? Worsening of symptoms instead of triggering. So I usually ask the patients, well, like when you're lying totally still here with your head for 5 minutes or 10 minutes, is your dizziness totally gone? Is it 0% or is it 10% or is it 90%? And vestibular neuritis will usually say, well, it was 100%, but now it's maybe 80% or it's 90%. Right? It's still there. It's still very much there. But the BPV patients will usually, and that's like, they will usually say, oh, it's still there, it's like 10 or 20% maybe for the ones that are presenting early, or maybe 30%, but it's better. It's definitely better, right? And then sometimes you get patients of personality types who cannot describe their symptoms at all. That's where you get problems with this. Oh, I cannot gauge this, or this is impossible. And I can emphasize that I hate being dizzy or having nausea, so I can emphasize for that. But I think I think it's great that Etlow actually acknowledges this gray zone in their recent papers. Okay, but you have your monosymptomatic patients, and in like if you want to categorize them, the two questions are: is it better when you're lying still, and is there a trigger? So it's better when you're lying still. Then it's episodic. If it's not, then it's constant. And it can be triggered, right? There's some kind of specific way of moving or stimuli that makes it worse. or spontaneous, you cannot trigger it. It's either there all the time or it comes and goes without you knowing how to stop it and start it. So, and this is how we get our categories of AVS, sEVS, and tEVS, and your differential diagnosis, which we just went through. So I won't go through these. We call it AVS here. I'll just mention that we call it AVS here. Yes. And there's a silent S in the beginning because it's spontaneous AVS. We do also have a category actually called, in some papers, called triggered AVS. But you notice in many of the tables that I've shown and in many of the papers, they just leave this out. And the triggered AVS, those are the traumatic patients that are still dizzy. It might be one of my most common patients that I see. It's not true AVS, it's without nystagmus, but they have constant dizziness and they've hit their head. So if you have someone with post-commotio, post-concussion headache, they can oftentimes be dizzy. But they do not live up to the criteria of AVS with nystagmus, but they do have constant dizziness, but without nystagmus. And those are the ones. Then you also have patients who have diving accidents or like have I think it's perilymphatic fistula. That's the diagnosis, I think it's called. Those are also emergencies, but they are ENT emergencies. And you have to call an ENT right away. And they're often left out, and I think it's right to leave them out because there's so much terminology and it's a bit complex, this area, at least to begin with, right? So it's good to leave them out. But just know that there are a triggered AVS, and with really specific symptoms, you should know about that. Okay. And then we have the main gray area is usually like someone who's dizzy right now. Is it constant or is it not? Do they have nystagmus or not? And sometimes they have, to make it even harder, they have this pseudo-spontaneous nystagmus. So that's why I have this gray area. And I like to say that when I have these gray area patients, if the history sounds like a BPPV, then I'll do the Dix-Hallpike. If the history does not sound like a BPPV, then I'll go in this direction. And this is where Peter Johns would probably say that, oh, you should. We probably do know that this is AVS, and we probably it's just a matter of knowing enough or teasing it out enough. And that's not my experience. So, and again, again, it may be me, but I think there is this gray area where I think sometimes doing this whole pack and getting a really specific sign, like this is totally BBV history, but they do still have the nystagmus after I've been sitting with them for 5 or 10 minutes, then I'll do the Dix-Hallpike test or head roll test, and if they do have a definite, clear nystagmus that shows BBV, then I'll go with that diagnosis. But I might consult our neurologist or a friend who actually is a enthusiast in dizziness as well. Yeah. Okay. I just wanted to show you here. This is from the titrate algorithm that I moved past before from Newman, Torker, and Etlow. And I just wanted to show like episodic, triggered, spontaneous, acute vestibular syndrome, spontaneous. But this is the one that they often leave out. Triggered, right? This is usually traumatic or toxic. And here you see head trauma, or whiplash, and so on. Barotrauma or blast injury, right? Perilymphatic fistula, and then toxic. And again, this is not necessarily with nystagmus, so don't don't use the hint test on these in the same way, right? If you have someone who's dizzy and has just been diving and maybe don't have nystagmus, then call an ENT doctor instead, right? So the hints test applies to these patients down here, not these, and you have to have spontaneous nystagmus, right? Or yeah. Okay, so back to the clinic. This is a picture from the internet that I've got, which happens to be one of our rooms in my hospital. This is one of the few isolation rooms looks like. Usually we don't have isolation room. We have isolation rooms. We have curtains in between our beds. But when I have a patient, I will take. I'll do like this. I'll keep them from triage. Sometimes when I'm in triage, I get this patient and I'll say, okay, lie still. While I'm getting the history, I'll put them hand on their head for 5 or 10 minutes while I'm getting the history. And I'll ask, okay, then I'll then I'll tell the nurses to get a line, give them some kind of liquid or fluids, I don't care which one, and then give them antiemetics, but nothing else, no benzos, no antihistamines. Because that will disguise that will mask my findings. Okay. Then depending on what I hear from the first couple of sentences, I'll do an ECG or VBG. But most of all, I just check for quick nystagmus. If they have quick nystagmus, then I actually don't need a lot of the other tests like ECG or VBG, because I know that it's a dizzy patient from an autoneurological course until proven otherwise, and I don't need these things. This is the Frenzel test. I'll do the if the patient is not like totally bad in a bad way, then I'll do a quick neurological examination looking for the dangerous D's, ataxia, and sensory-motor findings, and also Horner syndrome, right? I'm not always getting them up and walking at this point, because that's oftentimes impossible for them. But it's something that I will consider at the end of my exam. So the logistics of this is not as easy always. I'm looking forward to the Peter John's video about the logistics of how to do these tests and how he does it from start to finish. But this is usually how I do it. And then you'll put on the Frenzel goggles. If we have these Frenzel goggles, if we don't have them, doesn't matter. You can use paper instead. And then you'll do your history and your neurological exam, as I said, and then you'll ask like now you've been standing with the patient's head in your hand for 5 or 10 minutes, and then you'll ask, is it better when you're lying still, when I'm holding your head here, and when you've been lying for a little while? And then if they say yes or no, and can it be triggered, yes or no, then you kind of say, well, is it a patient where I used to use the HINTS tests, meaning that they have constant dizziness and they have nystagmus when I'm looking at them? Well, then I'll do a HINTS test, unless the history is really, really BBV-like. Then I'll do the Dix-Hallpike test and head roll test, or I'll just move right to this if they don't have nystagmus and they're becoming much better when they're lying still, then it's slam dunk, right? And if they don't have any nystagmus and they don't have and the Dix-Hallpike test are negative, then I'll get them up and walking at this point if the meds have kicked in, and see if they can walk and sit. And if they can do that, then I'll go to the medical stuff, and then they've been triaged, or like triaged plus. Sometimes I don't have time to do all those things. I make someone else do it, but yeah. Okay, so moving into the specific syndromes. So AVS, that is stroke until proven otherwise. How do we do the HINTS exam? And there's a great video here, excellent video on how to do the HINTS plus exam. And especially this one, how to perform the head impulse test, the magic move, is highly recommended, because the head impulse test is the most important one. tEVS is almost never other than peripheral. And the nystagmus is almost always unidirectional, right? Sometimes you do get the bidirectional ones or the vertical ones occasionally, but most of them is unidirectional. So it all comes down to the head impulse test, and that's what you have to do. Drill. Okay, so the head impulse test. So you will hold your hands high up on the head over the ears, holding the skull, not the jaw. Because if you hold the jaw, that's kind of wobbly, and what you actually want to do during the head impulse test is that you want to use your big muscles, not like you have to straight hands, straighten your elbow, and then use your big muscles in your triceps and biceps to induce small, like 10 to 15 degrees movements, and quick movements. And look at the video from Peter Jones to see how it's done. But that's what you want to do. You want to stress the vestibular syndrome. Ed Lowe usually talks about, it's like the stress test for the heart, but just for the vestibular syndrome. You don't want to just make the patient walk a steady pace. You want to make them run. You want to stress the heart, and that's what you do when you use your big muscles, not your small muscles in your hand. So your wrists should be straight as well, or wrists should be relaxed, but you're not moving the head with your wrists. You're moving them with your big movers in your triceps and biceps, right? That's how you get this quick movement. And then if the nystagmus is towards this side, like to the right, then you'll move away from that ear, and whether you move from central from central to off to lateral, or you move from lateral to central, it's kind of depends. But Peter Jones has a good argument in, well, if I'm getting a bit too enthused and I'm starting from central to peripheral or central to lateral, then I might twist too much and potentially hurt the patient, and that's not good. I don't think it's a high risk at all, and this movement in general is not risky at all, not for dissection, not for anything. No studies, no cases has come out that has been dangerous, and it's been done thousands, maybe millions of times. So far, no problems at least. So I would usually do it like this: place the patient's head a bit off center, make them fixate on your nose or some other point, and then move them with your big movers in your triceps and biceps quickly to the center. And maybe just before doing it, you will have them relax their neck, and that's usually the most hard thing in this test, making them relax in your neck. Okay. The nystagmus part is just doing like this, having maybe a bit more than an arm's length, or maybe something like that. This is a bit less. I would encourage you to stand a little bit farther away. And then at two-thirds of the extreme, because you can have extreme gaze nystagmus, like in the end. Some people have persistent nystagmus. Most people have a few beats, but you want to eliminate that. You want to like get to the extreme and then a little bit more to the center again. Then you have 2/3 of the center, or 2/3 of the peripheral, and then you can see if they have nystagmus. And you want to use the paper test or something to like fix to remove the fixation reflex, because then it will come out in nystagmus. Okay. And you'll do it up and down and left or right. And then you'll do the cover test, or it depends. Different books and different papers describe what the test is called differently. In general, what you do is you place something over the patient's eye. The eye that you're going to test, you place something over that eye, and then you move it to the other eye, and you'll see if the eye that you just cover, like when you uncovering it, you'll see if the eye goes up or down. If it goes from side to side, horizontal, that's normal. That's a lot of us have this latent strabismus, I think it's called. But if it goes up or down, then it's positive. And whether you look at one eye or the other is, you can check out the studies yourself and how to do the test of skew. And check out Peter Jones's videos. I at this point I'm not quite sure actually which one is recommended, because it's set differently in different studies. But at least you can probably do what you call the uncover test. So you look at this eye once it is uncovered, and you see if it goes up or down. But it probably doesn't matter too much. Okay. As we said, Hint's test can be either peripheral or central. And as I also said, I would rather that you do the nystagmus test first, because then you kind of know that if there's no nystagmus, there's no use to go through these. Because then it's not a. I mean, you could do the test of skew maybe, but the HIT test is unnecessary. You cannot use it because if it's central, you can. Then it's not like my head impulse test would be central as well, right? So okay. So for the hints test to be peripheral, all test has to be peripheral. If just one test is central, then you cannot rule out the stroke. And we talked about why you should not call it a negative test. Once you want to do the hints test on a patient, they will either come out with a vestibular neuritis diagnosis or they will come up with a stroke diagnosis. Right? You cannot have someone who's there was nothing wrong, you can go home. That's not. And then you've used the hints test wrong. Okay. So central. What kind of test will point towards central? Well, if you have a spontaneous vertical nystagmus, meaning up or down. I've seen this several times in Wernicke's patients or patients with intracerebral. Usually it's like high intracranial pressure or something like that. But if you see in a dizzy patient, then it's then that is problematic, and meaning that they might have a central lesion, right? If you have someone who has bidirectional, meaning that if you look to the right, then it beats to the right, and if you look to the left, then it beats to the left. That is direction changing or bidirectional. Nystagmus, that is also central until proven otherwise. You can look at the Tanutzer study that I mentioned in the beginning to see how much it seems like it's a central one, how much the likely ratio is, but you'll admit these patients for stroke workup anyway. If it's peripheral, I'm Danish here again, but if it's unidirectional, then that could be peripheral if all the other tests are peripheral as well. And our tips or tricks here is use the Frenzel. You have to remove the fixation. They must lie still for a few minutes. The nystagmus has to be 2-3 of the extreme angle, right? And if they are using alcohol or phenytoin, it may be false positive bidirectional nystagmus. Okay. Then for the head impulse test, if there's no catch-up saccade, meaning that it's normal, that's where all the contraries or where all the terminology problems are. That means that it's central. A normal test here would be pointing towards central. You have to admit the patient, and it's only because you selected the patient right, the AVS patient with nystagmus, that is why you can say that, okay, this could be central. If you test any other patient with that, then it's useless. And yeah, that's why it's so important to mention that they have to have nystagmus. And then you have the catch-up saccade, and it's opposite the direction of the nystagmus. So the nystagmus to the right, then when you turn the head towards the left, then you will have a catch-up saccade, right? As we just showed. And we just talked about record, like the tips for this is record slow motion on the phone, turn the head towards the midline. As we said, that might be better if you're a bit stressed, so you don't twist your head too much. It's small movements, just 15 to 20 degrees. And the movements, you can relax the patient's neck first, maybe with some random movements, and then do the fast one. Use the big, your hands holding the head up high over the temporals, and not the chin. And straighten your arms. Use your big muscles, the triceps and the biceps. Is the stress test, not anything, not just moving the head. Okay, and then you have the test of skew. If there's a vertical or diagonal skew, then it's central. And if there is no skew or it's horizontal skew, then it's normal. Okay, it's rarely the only finding. Focus on one eye, the one eye being uncovered. That's and here's the terminology problem is like Etlow calls it the alternative cover test. That is a specific test in like both these tests are probably good, but they use different like actually different tests in as I understand it. But I'm no ophthalmologist. I might just be confused here. But as I described, that's how I do it. And then HINTS plus hearing loss. I'll just flicker my fingers between their ears and say, does it sound kind of the same? And if not, then I'll if there's a new onset hearing loss, then it's an eye care stroke until proven otherwise, or it's a labyrinthiasis. And this is where, as I talked about, it's kind of hard to distinguish these two. If it's highly inflammatory young patient with CRP and maybe subfebrile, then it's probably labyrinthitis. And I will always ask the ENT doctor there to make the distinction. And if it's not totally clear, then you probably have to admit them as an eye care stroke. And then we'll test the gait. And I think in the HINTS test, the gaits should be part of it. In the HINTS plus, it should also be gait test, because that is that's part of it, I think, with the acute imbalance syndrome. Okay, if in doubt, I guess if you don't know what to do, then you can always do a CT scan and admit them on acetylic salicylic acid. That is not like if this is as we've been doing this for almost 2 hours now, and this is complex, right? It is a bit complex, and there's difficult terminology and so on. And until you've done it a few times and you have someone who to show you how to do it, it's complex, right? So and the reason why we're doing all this stuff is just to not admit all patients with CT stroke workup. That's like the main purpose of all of this, and not miss thrombolysis on some patients and so on. But if they're beyond the embolectomy stroke window, thrombolysis window, then you can always, if you're in doubt and you don't know who to ask, or you don't have anyone to ask, you can always give the CT. Just know that if it's negative, you cannot rule it out, and then admit them, and then someone will see them the next day. That is a suboptimal, but not at all bad way of doing it if you don't know what to do. And then medicines. Well, antihistamines and benzos, they will reduce the findings, and they will also be detrimental to the healing, according to ENT doctors. So I usually don't use them, and I only use them in the really like the first day, when I have made the diagnosis and I have like a patient cannot be anywhere, they're just miserable. Then you can write a really, really small prescription of antihistamines, for instance. But yeah, okay, and this is the same kind of box, just from Etlow, and you can read this yourself. But there might be some points that I didn't get across, so check this out and pause the video and read this. Okay, so who gets the HINTS test? Constant dizziness with nystagmus and no other neurological findings, meaning monosymptomatic dizziness, and no other, like, it shouldn't be a dizziness plus, it should be dizziness, nothing else. And how do you do it? Peter Jones' YouTube videos on the HIT test. Okay, moving towards tEVS. And tEVS, why do we even bother? Like BPV and orthostasis, they're usually not dangerous. Why do we bother? Well, this is why we bother. So I've done several lectures on probabilistic thinking, and you can check out those for more details on this. But in general, if we have a dizzy patient, the likelihood of the accumulated likelihood of all diagnoses are 100%, right? So the precise probability of these differential diagnoses may be, I don't know, 20%, 10%, something like that. But if you don't know anything about how to do the HINTS test or anything like that to rule in or rule out a stroke, then if you can rule in this one at least, because if that then you can rule out this stroke, because if this one goes up, then the other ones must come down, because it's a closed system. There's only like so many diagnoses, the sum should be 100. So if I diagnose BPV really consistently, then I can rule out the stroke and all the other conditions. But the devil's in the details here. Peter Jones has made this video called BPV equals Dix-Hallpike test. The patient gets dizzy and you see nystagmus. That's a myth, right? You need need to know which nystagmus is there with which kind of BPV, because if you don't, then when you're doing this whole pike, and especially if you're doing your lateral head roll movement test, right, then you may misdiagnose a stroke, because the spontaneous nystagmus that you're doing a head roll test on is, well, it is pointing towards one of the ears, and it is horizontal, but it's not fatigable, and it's definitely not getting better, so on and so forth. Like, so you need to know the syndromes here in order to what I just said about ruling BPV in, and then you can rule stroke out. You need to know the different BPVs. It's not just having some kind of nystagmus. You need to know the specific nystagmus is, or at least to a certain point. If you really want to get into the weeds, then this article is probably the best overall article on BPV that I know. Here you can get all the answers on the questions that you are thinking. Yeah. So we're still here in the room with the patient. We're here where they don't have any nystagmus, or they may have a BPV history, but maybe we're a bit doubtful whether they have nystagmus, spontaneous nystagmus or not. We'll do one of the BPV maneuvers. So what kind of the maneuvers are there? Well, there the Dix-Hallpike test, and you turn the patient's head 40 degrees or 50 degrees, 45 degrees, something like that, to one side, to the side that you want to test. You're testing the ear that you're turning the head towards, and then you lie them on a table. You lie them on the bed, and you will either have some kind of cushion behind them, or you will make it so that they are sitting so that they will get their head outside of the bed at least 20 degrees, so they have like this extension of the neck. It's important. And then you will explain to them what you're going to do. And I usually say that, well, if this is BPV, it has to become worse before it becomes better. Because if it becomes worse, then I have the diagnosis oftentimes, and then I can treat it, right? And also, even if I don't have the specific diagnosis, but I think it's still BPV, then you have to like provocate the dizziness, because then the brain will eventually make up and heal itself, right, from this stimuli, or become numb to the stimuli, and then kind of heal itself. It's fatigable, that's what I'm trying to say. Okay. So this is what you do for posterior canal, and what you're going to see, if it's positive, is you'll see a geotropic nystagmus with a torsional component, and as you'll see in some of Peter John's videos, depending on where the patient is looking, then there might be a vertical component as well. I think I can remember which way they should be looking, but I think it's if they're looking towards their uppermost ear, then you'll get it vertical, and if you're looking towards the lowermost ear, then you'll get the more torsional component. I cannot remember. Check out his videos on vertical nystagmus in positional testing. But just knowing that vertical nystagmus here is not pathological for stroke. It's not something where you should consider stroke or central cause. If you have on the other hand, if you have a downbeating nystagmus while doing this is where you might consider the anterior canal, but it's so rare that you should probably just work them up as strokes anyway, at least according to Etlow. The head roll test is one of the most simple tests that you'll ever do. It's lying the patient on the bed. I usually have a slight angle in the bed, maybe 20 or 30 degrees, and then you can just turn their head quickly to one side and then the other. This is testing the right side, and then don't test the other side right away. You have to fatigue the nystagmus, or it has to go down and then be back to normal again, and then you can check the other side. And a positive test here is nystagmus beating towards the ear that is affected, right? So if you have a problem here in this ear, then it's beating towards the ground. And if you have a problem in this ear, then it's beating upwards really fast. And remember, with the horizontal canal BPV, there will be bilateral nystagmus. So the nystagmus is also present when you're moving this patient to the other side, but it's just not as present. So if you have this ear is sick with a canalithiasis, then it's and this is where it's less specific. This is really well documented. This is less well documented. So in the BPV guidelines, it's less well described. So that's why I'm kind of not too specific about this. But in general, you will see if this ear is sick, you'll have geotropic nystagmus downwards, like if it's a canalithiasis. But you might, when the patient is turned to this side, you will see a slight nystagmus downwards as well sometimes. And in the cubulothiasis, you will see nystagmus upwards, apogeotropic. And here you'll see, if you turn them, if let's say this ear is sick, then you'll see really strong up here, meaning that it turns it points towards the ear that is sick. And if you turn this to the other side, this was the sick ear with cubulothiasis, then it'll usually be a less strong apogeotropic nystagmus. And these patients will have a lot more longer lasting nystagmus, and usually they will be more AVS-like when you're saying that they should lie still, these cubulothiasis patients, right? So. Okay, so what we're noticing when you're doing the test is the latency. Like there should be a little bit of delay, a few seconds until it comes, and usually patient subjective will say, "Oh, now it comes," when you're hitting the right area. The duration in the books is usually 30 to 60 seconds, in my opinion and my experience. It can be more than that, especially if you're using the frontal goggles, then you can kind of see the small movements for a long time. But oftentimes the patient will say, "Oh, it's getting better after maybe 30 seconds, 50 seconds, something like that." So that's true. But with the cubulothiasis, it's usually a bit longer, maybe 2 minutes sometimes. And the subjective symptoms are always subjective. Sometimes it lasts a bit longer than that, but oftentimes they're kind of matching up. And you'll notice the direction. Is it apogeotropic or geotropic? And you'll notice whether there's a torsional component, because if you're doing a horizontal canal test like the supine head roll test, and there's a torsional component, then maybe it's actually a posterior canal BPV, right? And if you're doing a Dix-Hallpike and it's actually a horizontal nystagmus, then maybe it could be the horizontal canal instead, right? So that's why the nystagmuses are important to pick out, and it's hard sometimes. And I'm not saying that you should perfectly be able to know which canal it is, but at least you should be confident enough that it's not a stroke that you're misdiagnosing here. Okay, the treatment is multifaceted, and it's sometimes something that we gloss over, but I think it's important to go into. So if you know what kind of canal it is, then you'll do a reposition maneuver for a Dix-Hallpike positive patient, meaning that they have posterior canal BPV. Then you'll do a Epley's maneuver. If you have a patient who has a horizontal canal BPV, there is more maneuvers that you can do. I would usually use the Gaffoni's, but there are different ways of doing reposition maneuvers as well. If you're not quite sure which one it is, but you think it's a BPV still, and Then you can use what you call like rehabilitation maneuvers, unspecific maneuvers such as I cannot remember the name of it, but I have it on another slide here. You'll do, and then you'll just rehabilitate the patient because, and maybe send them to an ET doctor if they can make it out, or refer them to them, because these things will almost always get better as the brain kind of, like, there's a trigger from here going up to the brain, but the brain will, if it's getting triggered all the time, oftentimes it will just numb that trigger after a while, or maybe the stone will go into itself. Or the thing is, if you rehabilitate by just moving, then usually it'll become better. It's fatigable and it'll get better by itself oftentimes. Medication, it's in red here because it's nothing that you should use, and if you really need to use it, then it's in the first couple of days and not anymore. And many ENT doctors will tell you, and I'm not sure the studies on this, but I guess it mechanically makes sense that the rehabilitation of the brain will be slowed because you're slowing down the processes that are actually useful for the patient, for the brain to reestablish itself and rebalance itself. What you do need to give them is information, expected time course, and the course of it, which is unknown almost always, and the relapse rate, which is kind of high with BBB. I can never remember it, but it's in my note on this that I give to the patients. Admissions, you may consider admissions if they are totally like if they cannot provide for themselves, especially if they're elderly, then sometimes they need to be admitted anyway, even though you don't think it's a dangerous condition. But sometimes you cannot rule out a dangerous cause because it's an elderly patient. They cannot come up and walk and stand by themselves if they don't walk at baseline. So yeah, and then you maybe arrange follow-up depending on where you work. But oftentimes, if you're not quite sure, then you may follow up with them, or if it's a more complex patient. And this is what I just talked about. Like if you do a diagnostic test and you have a geotropic torsional nystagmus, then it's posterior canal BVV. If it points towards the ear. But if it's a geotropic, like pointing towards the ground, right? But it's a horizontal. But if it's a horizontal nystagmus, then you should probably do the head roll test instead, and so on. And so you should do these tests. Like if you see something that is not typically of the posterior canal, meaning that you see a horizontal nystagmus, then you should try to do the head roll test on that side instead, and vice versa. If you do the head roll test on a patient and you see something that is torsional, then you should do the Dix-Hallpike test. And it's not easy. You usually don't do all 4 tests like you do. And I mean 4 tests meaning 1 on each side on the Dix-Hallpike test and 1 on each side on the head roll test. I usually don't do 1 of each. I do it until I hit gold. And once I hit gold, then I stop. But if I don't hit gold, then I have to do all the 4 tests. Okay. So why bother doing repositioning maneuvers? Well, the problem is in the ED they're time consuming. There's a learning curve to doing them good, and actually it's a benign diagnosis. Why should we do them? On the other hand, it's much more effective than conservative management rehabilitation. If we do get the canal, it will heal faster. And the numbers you treat in the ED is 1 to 4 with the Epleys, less so with the faster healing horizontal canal BVV. And I guess the Epley numbers needed to treat makes sense. Like conservative management probably doesn't work as well for the posterior canal BVV. That's why the ENT doctors are usually seeing them in their studies. But the horizontal canal BVVs probably will heal themselves a lot of the times before getting to the ENT office. So it's especially the posterior canal BVV, and that's good because those are the ones that are easier. The horizontal canal BVVs can be harder. There's virtually no complications to these tests, right? Most of our treatments have harms, but this one doesn't really have any, and they reduce the fall risk in elderly. So why not do it? If you have a patient who has the geotropic torsional nystagmus, then you'll do the Epley's towards the sick ear. Usually just do this whole pike from the beginning, and then you'll go over to an Epley's maneuver, and I'll show you how. And there's also the Simont maneuver. I've never done that. And then you'll do for the geotropic. If you have a horizontal canal BBV, then you'll do the Guffonis. And for the epigeotropic, like the cupulolithiasis, I'm not quite sure what to do there actually, and I know the papers are not quite sure either. But you can do the Guffonis, you can do some other tests that I'll show you that are unspecific. Okay, so Evelyn's maneuver. I know some doctors just do the Dix-Hallpike and the Evelyn's maneuver in the same kind of way. Also, when you do know which ear is a problem, then you'll just do it with the Dix-Hallpike to begin with, and that's fine. So it's oftentimes taught with the Dix-Hallpike in the beginning. So here is the Epley's with the Dix-Hallpike in the beginning. So there's a right ear that is sick. We know that already from the test we just did. And then you'll just lay them down, and with 45 degrees here with the head tilt for 20 degrees outside of the bed. Move and then they will have nystagmus and it'll feel bad, and then tell them that for each movement they will feel bad again. That means that the crystal is moving around. And then from this position, you will have to move them 90 degrees to the next position. This is step 3 here. And then after that, this is important, I usually tell them, look towards your left shoulder and keep looking there. You should fixate your gaze there and not move it. And then you should move up onto your left side. And that's often hard for a lot of patients to do, so that's why you have to be really clear about that. And then they do that. And this is also held for 20. They say 20 to 30 seconds. I would usually say until the nystagmus is gone. And it's oftentimes 30 seconds, sometimes longer. And the patient is brought onto their usually sitting position, and usually sitting position with the legs outside of the bed, but and not as shown here, but it depends. For the Guffonis test, this is where the right ear is sick with a canalithiasis, and you have a nystagmus that was beating towards the ground when you did a horizontal canal BBB test, meaning the head roll tests. Then you sit them up and you lie them down on the side that is opposite the sick ear. You can hear that this is, I often have to think about this. You have this written down on a piece of paper, and then you turn their head so that their face is in the bed, with facing the bed. And then they'll hold this position for a minute or two, and then they sit up again. If it's an apogeotropic nystagmus, then you can use probably a cupulolithiasis on this ear, meaning that when you did the head roll test towards the left here, then they had a really strong nystagmus pointing towards the sky. That means that it's probably a cupulolithiasis in this ear, meaning that the way that we may specifically treat this is by lying them down on the right side and then pushing their head towards that. So it's opposite of the normal canalithiasis, right? And all of these pictures are from this BPPV guideline that I just showed you, so you can check it out by yourself. and they're kind of like papers are kind of vague on this, so that's why I'm also kind of vague on this. But in general, you can read it yourself when you get these patients. I usually, what I've been taught is usually doing this as well. This is not a specific canal maneuver. This is the Brand-Darif rehab method, where you make the patient sit and then lie down and then look up towards the sky and then up again and then down, and you do like sit up, lie down, look up towards the sky for 30 seconds, up again 30 seconds, lie down for 30 seconds, and then you do this 3 times each side, 3 times a day. Yeah. And then you follow up with ENT because you haven't found the cause specifically. You cannot treat it. Usually, you can always do a Brand-Darif. If you don't know which canal it is, then you can do an unspecific rehabilitation test and then just make them refer them to an ENT doctor. That is acceptable to do. BPV resolution at 1 week is 25% versus 75% with Epley's. Faster self-limiting resolution if lateral BPV. Yeah. Okay. So that's the now we get to the like. Okay, they don't have any nystagmus. What do I do? And this is where it's kind of hard because you have to make up your own mind on what to do. So it's not triggered EVS. It's not AVS when what is left is the other, like medical stuff and psychological stuff. It can be traumatic AVS. It could be, trauma twice, but it can be triggered AVS, which includes trauma. It can be sEVS, spontaneous EVS. So the first tEVS, we already talked about the tEVS. And we're talking about this area down here. We talked about these things, call an ENT doctor. And if you have a clear history of there's no nystagmus, but you have a clear history of head trauma, it's post-commotio, then explain what post-commotio is to the patient, be empathetic and use compassionate care. Encourage them to, like, there's this great Canadian post-commotio site that I cannot remember the name of right now, but in general, it's light to moderate exercise. It's you need to have sick leave if you need to. So contact your primary care physician and and temporize. Like, you know that there's a big psychosocial component in this probably, and it's okay. We all have psychosocial components in our problems. Just know that you should not go to the ED every time and not be scared. But it's something that we will resolve. But you need to temporize and manage the symptoms for now, and then they can be really severe. So it's not an easy thing to do if they've come to a place where it's like severe headache and dizziness. Okay, but that's that. So sEVS. Make sure there's no nystagmus, remove the fixation, yes. And then you do the history, and if they do have some kind of polypharmacy or new medications, especially blood pressure medications or other dizziness inducing medications such as benzodiazepines or just good old polypharmacy, then check out, in Denmark we have something called this seponeringslisten. Like, check out the medication that should not be there. Make sure that you can actually pause them or remove them without tapering them, and like, don't remove high dose benzodiazepines right away, right? You need to plan that and dose reduce that over time. But in general, that's something to think about. Then do an ECG and consider blood samples, especially for hypernatremia and anemia, some of these things, creatinine, like kidney failure, dehydration, so on. But do not think everything is TIA. Do not order CT scans routinely. And do we order troponins? Because we do know that ACS is on, like, atypical symptoms could be dizziness in these papers. And SGM has done a study on this, like has done a something on this. And in this retrospective study, elderly patients presenting in the emergency department with non-specific complaints, the diagnosis of ACS was rare, and troponin testing had limited value. So there's this, on the one hand, we are told that ACS patients can present atypically, especially with dyspnea or influenza-like symptoms. Less so with dizziness. And if you find a different cause for their dizziness, and I guess don't take troponins. And in this cohort, there was no reason to screen with troponins at all. That doesn't mean that you should never take troponins, but troponins is not part of the workup. It is something to consider if you have no other like clue, and you might think there is some kind of ACS in this. Okay. But what about TIA? Well, the short answer is we don't know. Peter Jones has made a great video on this as well, and you can check out Ed Lowe's Grace paper. I think they also say like consider it, but they don't say how to consider it, and they acknowledge that it's hard to find out, and we don't quite know how to. But if you have patients who are at high risk, sometimes they used to use the ABCD score, but they don't encourage that anymore. But if you have someone who has high risk, they don't usually are dizzy. They don't have any other like reasons to be dizzy, but they have specifically like TIAs are usually symptoms below like less than an hour. If they have symptoms for less than an hour that are abrupt onset, and it's not arrhythmogenic, and it like comes like on off, and then you can consider it, but it's not something that you routinely should consider. They usually, what they say, kind of remember, I think it's from the paper here. Consider TIA if no other causes are found, and multiple vascular risk factors, and dizziness, plus other stroke symptoms in history, the deadly Ds. Of course, if they only have monosymptom, if they have other stroke symptoms, of course, and they don't have no other like, because the most common one is sEVS. Is vestibular migraine, and here's the diagnostic criteria for vestibular migraine. And it's a lot of them is the same as the migraine criteria, like at least 5 episodes. That's the migraine criteria. Why 5? Well, it might as well be 3 or 4, but in general, because we treat with less so. But do they have current migraine or aura? Or previous ones, to have one or more migraine features with at least 50% of the vestibular episodes, right? So headache with at least 2 of the following characteristics: one-sided, pulsating at quality, moderate to severe, meaning that they have to lie down oftentimes, and aggravating by routine physical activity, right? And photo of, so they have, or they have phonophobia or visual aura. If you have one of those 3, and the headaches have to be specifically with 2 of these 4 syndromes or symptoms, and there's no better way to describe it, then it could be vestibular migraine, and they have to be treated with migraine medication. Okay. And if they're young, then it's probably it. If they're older, then you could probably consider CIA. That's kind of my way of thinking about this. The thing is also, the duration here is 5 minutes to 72 hours. I know because I've worked in migraine clinics, and with both children and adults, that children can have migraines lasting 5 to 60 minutes, but usually adults is above 60 minutes. And it's usually usually has to be an hour to 72 hours, but not above 72 hours, and usually not below. But here apparently in vestibular migraine, they have used the children criteria. But it's important that TIAs are usually less than an hour, right? It's usually 10 minutes or something like that, and that's uncommon. And the reason why I'm raising this point is because that is uncommon in migraines to have only 10 minutes of symptoms. It's almost like unheard of in adults to have that. But with children you can have this. It's part of the criteria for children, but not for adults. That's why I'm kind of raising my eyebrow on this. And because I think it's important, if you have someone who's only had symptoms for less than an hour and it came on suddenly and so, like, then you should consider TIA in the older patients and not vestibular migraine. Okay. Then you have these patients who have, I guess, AVS without nystagmus. Again, I would not call it AVS without the nystagmus, but constant dizziness without the nystagmus. And you do the Dix-Hallpike test maybe, and it's normal, and you do the head roll test, it's normal. Then you kind of left with this: can they walk? Well, if they can walk, then, and it's not this Machner acute imbalance syndrome. Well, that's when you kind of can just, if the patient is unable to, then you can usually send them home, right? You can usually send them home as long as there's no blood samples that are off, and then they feel okay, and then they can follow up with their primary care. And it's okay if they cannot walk and they cannot go home, but they're not ataxic, then you can always admit them for unspecific reasons, right? Sarcopenia and elderly geriatric problems are common in this population group, right? So, but that's a different lecture on geriatrics and geriatric syndromes, which I've also done. And I guess all of this, like the other things here, usually it comes down to being multifactorial, frailty, imbalance, like polyneuropathy, sarcopenia, and also if you have fallen once and you're not sure on yourself how to walk. I've had a lot of patients have PVPD who are not sure on how to walk anymore because they have sarcopenia or they've fallen, they have the hip fracture and so on. And it's totally logical to become scared. Also, younger patients can get PVPD, like paroxysmal persistent. Sorry, I can't remember but this is anxiety with dizziness, right? You have like not panicky syndromes, but it's kind of like it's anxiety, like it's multifactorial, but mainly psychological anxiety provoked dizziness. But the patient will not tell you that, and you can go into my lecture on functional neurological diseases to like how to approach these patients. But in general, empathize with them. Their symptoms are real, even though we cannot find them with our tests. And oftentimes we're moving towards a paradigm in functional diseases where we try to do positive diagnostics, meaning that it's not a rule out diagnosis, it's a thing that we can actually positively diagnose, especially in neurology, especially in functional neurological diseases. So oftentimes you can tease out that they're not faking this, they're just trying to but you can get from the history, it's not in all situations, and they can do some things but not others. And but if you have these patients, oftentimes it's better to maybe refer them to a specialist, and so they can follow them up and make a definite diagnosis. Okay, and you check out the medical stuff, especially polypharmacy, hypernatremia, anemia, stuff like that. Okay. And then just the pitfalls to end with here. Edlow's paper, the Grace paper, talked about these pitfalls based on the differential diagnosis on symptoms quality rather than the timing and triggers. Yes, that is a pitfall. That mean using hints testing in the wrong patients, those without ongoing dizziness and nystagmus. Again, here they actually agree, right? So finding a worrisome results, having false positive or false central head impulse tests in everyone else, that's true. Not recognizing that dizziness is worse with head movements and consistent with central causes, true. And ruling out ischemic stroke based on a normal CT scan, that's also. These are kind of basics, we already covered them. Then I think there's many other pitfalls, and the most important one being this one. As we saw, 97% in the beginning are using it wrong. So that's the dizziness lecture, the update. And I hope you found it useful, and please comment if there anything that I said wrong or anything that you want to add. And I'll see you again another time. Thank you so much.